Welcome back to the deep dive. Today, we're really honing in on pancreatic cancer. Think of this as your focused, high-yield revision session. We'll cover what you absolutely need to know.
Exactly. It can feel like a really overwhelming topic, pancreatic cancer. So our goal here is to, break it down, make it clear, memorable, and really useful for you. We'll hit all the key areas from the basic definition right through to the complications.
And we'll try to add some memory tips along the way, too.
Definitely. Anything to help make it stick.
Okay, let's kick things off with the definition. In basic terms, what are we talking about when we say pancreatic cancer?
Right. So pancreatic cancer is basically when cells in the pancreas start growing abnormally, out of control. And remember, the pancreas has those two really crucial jobs, making enzymes for digestion, that's the exocrine part, and hormones like insulin for blood sugar, the endocrine part. So a malignancy there can really mess things up systemically.
And are there different kinds we should be aware of?
Yeah, there are. We usually talk about where it starts, so cancer in the head, the body, or the tail of the pancreas. There are also rarer neuroendocrine tumors, but the main one, the one you really need to know, is adenocarcinoma. That makes up like over 80%, maybe even closer to 95% actually, of all pancreatic cancers.
Wow, 95% adenocarcinoma. That's huge.
Yeah.
And it most often starts in the head, you said.
That's right, frequently in the head of the pancreas. And unfortunately, that's linked to why the prognosis can be quite poor.
Why is the prognosis often so challenging?
Well, a couple of big reasons. Firstly, this type, adenocarcinoma, it tends to spread quite early. We call that early metastasis. Common places are the liver, the peritoneum, that's the lining of the abdomen and the lungs. Secondly, the early symptoms are often really vague, nonspecific, so people might not realize something serious is wrong until it's quite advanced.
So you've got early spread combined with late diagnosis.
Exactly. It's a tough combination. And just to reiterate, about 90% of these adenocarcinomas are what we call infiltrating ductal adenocarcinomas, typically arising in the head, neck, or that little hook part called the uncinate process.
Okay. You also mentioned something called periampullary malignancies earlier. What's the deal with those?
Ah, right. So that refers to cancers arising in the sort of junction box area around the ampulla of Vater. That's where the common bile duct and the main pancreatic duct empty into the first part of the small intestine, the duodenum. These cancers can actually start in the pancreas itself or the very end of the bile duct, the ampulla or the duodenum lining.
And does that location make a difference?
It can do, yes. Interestingly, cancers starting right at the end of the bile duct or in the ampulla or duodenum often cause symptoms like jaundice earlier because they block the bile flow sooner. So paradoxically, they sometimes have a slightly better prognosis because they get picked up earlier.
Right, that makes sense. An earlier warning sign. Okay, so we know what it is, but what actually causes it? What's the etiology?
That's the million-dollar question, really. The honest truth is, we don't know the precise cause of pancreatic cancer yet. It's likely a complex mix of genetic and environmental factors.
So no single smoking gun identified. But we do know about risk factors, things that increase the chances.
Absolutely. There are several well-established risk factors. Smoking is a really big one. Definitely remember smoking. Then there's advancing age, typically over 65.
Okay, smoking age.
Then family history, having relatives with pancreatic cancer or certain other cancers. Obesity is another factor. Chronic pancreatitis, long-term inflammation of the pancreas is a significant risk. Diabetes, too. And there's some evidence linking high intake of red meat.
Is there a way to maybe remember those key ones?
Yeah, you could try a mnemonic, maybe something like smoking, age, family history, obesity, chronic pancreatitis, diabetes, red meat. Same as CODR, maybe a bit clunky, but might help anchor them.
Safo CDR. Okay, worth a try. And you mentioned family history. Are there specific genetic links or conditions too?
Yes, definitely. There are known associations with certain inherited conditions like HNPCC or Lynch syndrome, as it's often called now, and multiple endocrine neoplasia or MEN-N syndromes. Specific gene mutations are also implicated, like BRCA2. Yes, the same one linked to breast cancer, and KRAS mutations are very common in the tumors themselves.
So family history, specific syndromes, gene mutations.
Right. And even some other medical conditions seem to be associated with slightly higher risk, things like inflammatory bowel disease, peptic ulcer disease, even periodontal disease, gum disease, and rarer genetic things like von Hippel-Lindau syndrome. It paints a picture of, well, multiple potential pathways increasing risks.
Okay, so a complex web of risk factors. Now, mechanistically, how does the cancer actually develop? The pathophysiology.
It typically starts within the cells lining the pancreatic ducts. The core issue is damage or mutations to the DNA within these cells. These mutations essentially mess up the normal instructions for cell growth and death.
So the cells just start multiplying uncontrollably.
Exactly. They ignore the normal signals to stop growing, they don't die when they should, and they accumulate, eventually forming a tumor. It's like the regulatory systems, the brakes are broken.
Got it. Faulty genetic instructions lead to runaway growth. Now, because those early symptoms can be vague, differentiating it from other conditions must be crucial. What's on the differential diagnosis list?
Hugely important. Yeah, the symptoms overlap a lot, so you absolutely have to consider other things. Common stuff first. Gallstone disease, peptic ulcers, think gallstones, peptic ulcers, GP.
Okay, GP. What else?
Other cancers in the area, gastric cancer, colorectal cancer, GC, inflammatory things like esophagitis, hepatitis OH, liver problems like abscesses or liver tumors, primary or secondary LL.
Right.
Then you need to think broader, too. Could it be right-sided heart failure presenting with abdominal symptoms, pneumonia near the diaphragm, a pulmonary embolism, even an aortic aneurysm, RPTA? And of course, you have to consider benign pancreatitis itself. It's a wide list.
That is a lot to rule out. What if the main presenting feature is jaundice? Obstructive jaundice. Does that narrow it down?
It helps focus things, yes. For obstructive jaundice, you're thinking about what could block the bile duct. So besides pancreatic cancer, you'd consider bile duct strictures, which could be benign or malignant themselves, a common duct stone that's got stuck, benign pancreatitis causing swelling that compresses the duct, and cholangiocarcinoma, which is cancer of the bile duct itself, so maybe BCPC, bile duct stricture, common duct stone, pancreatitis, cholangiocarcinoma.
BCPC. Okay, helpful. So thorough investigation is clearly key. Let's shift to the numbers. What's the epidemiology look like, particularly here in the UK?
Yeah, the UK stats are pretty sobering, unfortunately. It's the 11th most common cancer overall, but it's the 5th leading cause of cancer-related death. That disparity really highlights the severity.
5th leading cause of death.
Wow.
And what about curability?
Well, that's the kicker. Fewer than 20% of people are diagnosed when the tumor is potentially curable with surgery. The overall incidence is roughly 9 cases per 100,000 people per year.
And age, gender.
It's most common later in life, really peaks in the 7th and 8th decades, so 60s and 70s. Overall, no massive gender difference, but it does seem to be slightly higher in older men. Interestingly, there's also a link with deprivation higher incidence in more deprived areas in England, and it's seen more in white and black populations compared to Asian populations in the UK.
And survival rates. You mentioned the poor prognosis.
Yeah, the 5-year survival rate is stark. It's less than 5%. And sadly, that figure hasn't really budged much in the last few decades, despite advances in other cancers. Incidence rates have actually been increasing slightly in the UK since the early 90s, too. It really underlines the challenge we face with this disease. About half the cases occur in people aged 75 and over.
Stark figures indeed.
Yeah.
Okay, let's talk about how it actually presents. What are the typical clinical features a patient might come in with?
The presentation can be quite varied, and often the symptoms only become really noticeable quite late. Some classic ones, though. Abdominal pain is common, often in the epigastrium, the upper central abdomen, and it characteristically radiates through to the back. That's a key feature.
Abdominal pain radiating to the back. Okay.
Then, jaundice, the yellowing of the skin and eyes, often accompanied by dark urine and pale stools, and itching. Sometimes, new onset acute pancreatitis, especially in an older person with no obvious cause like gallstones or alcohol that should raise suspicion. So think AJA, abdominal pain, jaundice, acute pancreatitis.
AJA. Got it. What else?
Unexplained weight loss is a big red flag. Significant weight loss without trying often goes with anorexia, loss of appetite, and steatorrhea, fatty, floating, foul-smelling stools due to problems digesting fat. Think AUS, unexplained weight loss, anorexia, steatorrhea.
AUS. Any signs on examination?
Yeah. In more advanced stages, you might feel an epigastric mass, and sometimes a palpable non-tender gallbladder in a jaundiced patient. That's Courvoisier sign. It's actually quite rare, but classic if found. So e.g. epigastric mass, gallbladder, palpable. Other things can include nausea and vomiting if the tumor blocks the stomach outlet, or signs of GI bleeding like vomiting blood or black stools. Ascites or a swollen lymph node above the collarbone, Virchow's node, are late signs.
You mentioned Courvoisier sign,
Yeah.
and painless jaundice is often highlighted as a classic sign, isn't it?
Yes, absolutely. Painless jaundice is particularly concerning. When a tumor in the head of the pancreas grows, it can slowly compress the bile duct without causing much pain initially. So the patient becomes yellow, notices the pale stools and dark urine, but doesn't have that severe pain you might get with a gallstone, for example. That lack of early pain can unfortunately lead to delays in seeking help. So painless jaundice with pale stools, dark urine, and often abnormal LFTs point strongly towards this PJPD.
PGPD. And Courvoisier's law ties into that, right?
Right. Exactly. Courvoisier's law basically states that if you have painless jaundice and a palpable gallbladder, the cause is unlikely to be gallstones because chronic gallstones usually cause a shrunken fibrotic gallbladder that you can't feel. It's just the blockage is more likely from something downstream, like a pancreatic or bile duct tumor.
It sounds like many early symptoms are things people might ignore or put down to something else.
That's a huge part of the problem. Anorexia, weight loss, vague upper abdominal discomfort. These are so nonspecific. You might also see signs of the pancreas failing in its other job, steatorrhea, from lack of digestive enzymes, exocrine failure, or new onset or worsening diabetes, endocrine failure.
And the back pain.
Yeah, the back pain is often described as a dull ache deep inside, sometimes worse when lying flat and maybe relieved a bit by leaning forward. Again, easily mistaken for musculoskeletal pain initially. And one other sign, perhaps less common but important, is Trousseau's sign migratory thrombophlebitis, basically unexplained blood clots appearing in different veins. It can happen with other cancers, but seems particularly associated with pancreatic cancer.
So lots of potential clues, but often subtle or nonspecific early on, leading to late detection.
Precisely. Often it's the rapid onset or worsening of these symptoms that finally brings someone in, but by then the disease may have progressed significantly.
Okay, so if pancreatic cancer is suspected, what investigations are typically ordered?
Right, we need to confirm the diagnosis, see how advanced it is, stage it, and get tissue if possible. Imaging is key. The first and usually best test is a high-resolution CT scan, specifically with the pancreatic protocol, which means thin slices and different contrast phases to see the pancreas and surrounding structures really well. Think CT for crucial test.
CT first, what else?
An ultrasound scan, often done initially, can sometimes pick up a tumor or see dilated bile ducts or liver metastases. Endoscopic ultrasound, or EUS, is really valuable. That's where an ultrasound probe is put down the endoscope right next to the pancreas. It gives very detailed images and, crucially, allows for biopsies, fine needle aspiration to get a tissue diagnosis. Think EUS for excellent view and easy biopsy.
US sounds quite specialized. Any other imaging?
Yes. MRI, and particularly MRCP, magnetic resonance cholangiopancreatography, are very good for looking at the bile ducts and pancreatic ducts, especially if there are pancreatic cysts involved. So, imaging-wise, CT, ultrasound, EUS, MR, MRCP. Maybe think CUEM.
CUE, okay. And blood tests?
Yep, bloods are important. Liver function tests, LFTs, are vital. They'll often show a pattern of obstructive jaundice with high bilirubin and alkaline phosphatase. Checking serum glucose is important because of the link with diabetes. And then there are tumor markers, the main one being CA19-9. It's not reliable enough for diagnosis on its own. It can be raised in other conditions or normal even with cancer, but it can be useful for monitoring treatment response or detecting recurrence later. So bloods, LFTs, glucose, tumor markers, CA19-9. Maybe add BLT to CUEM-BLT. Getting complex. Okay. CT, ultrasound, EUS, MR, MRCP, bloods, LFTs, glucose, tumor markers. And what about staging and grading once cancer is confirmed? Staging is done using the standard TNM system. T describes the size and local extent of the tumor. TIS is carcinoma in situ. T1, T4 represent increasing size invasion. N refers to spread to nearby lymph nodes. N0 is no spread. N1 means regional node involvement. And M indicates distant metastasis. M0, no distant spread. M1 means it has spread to distant sites like the liver or lungs.
TNM, standard system.
And grading. Grading looks at how abnormal the cancer cells appear under the microscope. For exocrine cancers like adenocarcinoma, it's usually G1, well-differentiated, looks more like normal cells, less aggressive, to G4, undifferentiated, looks very abnormal, most aggressive. Biopsy is essential for grading and also confirms the type, like distinguishing adenocarcinoma from a neuroendocrine tumor.
Makes sense. Now, our notes mention specific NICE guidelines for diagnosis in the UK. What are the key points there?
NICE basically says if someone presents with obstructive jaundice, they should get a pancreatic protocol CT scan urgently. Same if they don't have jaundice, but another scan shows something suspicious in the pancreas. If the CT isn't completely clear, they might recommend further tests like FDG-PET-CT, which looks for metabolic activity, or EUS with tissue sampling.
And for cyst?
For pancreatic cysts, they usually recommend both CT and MR-MRCP for better characterization. They also have criteria for referring patients who might be suitable for surgery based on imaging features, and again, emphasize EUS with biopsy for getting more detail or tissue confirmation. The general theme is CT first, then layer on other tests as needed for clarity.
Okay. And for staging, what do the NICE guidelines recommend?
Pretty similar logic. A pancreatic protocol CT is a first step for staging everyone newly diagnosed. If the CT suggests the disease is localized and potentially resectable, NICE often recommends an FDG-PCT scan as well to look for any small, unexpected spots of spread elsewhere. And they acknowledge that sometimes you need even more info from MRI, EUS, or even diagnostic laparoscopy keyhole surgery to look inside the abdomen.
Right, build up the picture. And just briefly on histology, the main types.
Overwhelmingly, the primary solid tumors are ductaladenocarcinoma. That's the main one. You do get primary cystic tumors too, like serous cystadenomas, which are usually benign, and mucinous neoplasms, which have malignant potential. It's important to remember that most non-inflammatory pancreatic cysts are considered malignant or pre-malignant until proven otherwise.
Okay, a crucial point about cysts. So moving on to management. Once the diagnosis and staging are done, what's the approach in the UK?
It's very much a multidisciplinary team approach, usually in designated specialist pancreatic cancer centers. The plan is highly individualized based on the stage, the patient's fitness, and their preferences.
And is surgery the main aim, if possible?
Yes, surgery offers the only real chance of a cure, so it's always considered first. But, as we said, less than 20% of patients are suitable for surgery at the time of diagnosis, usually because the cancer has already spread or is involving major blood vessels.
And if surgery is possible, what operation is usually done?
For tumors in the head of the pancreas, the standard operation is the Whipple's procedure, technically called a pancreaticoduodenectomy. It's a major operation involving removing the head of the pancreas, the duodenum, the gallbladder, and part of the bile duct. For tumors in the body or tail, a distal pancreatectomy might be done.
And after surgery?
Adjuvant chemotherapy chemo given after surgery is standard practice now. It's been shown to improve survival rates. Usually it's a combination like gemcitabine plus capecitabine, often called GemCap. For patients who aren't candidates for surgery, things like ERCP with stenting can be used palliatively to relieve jaundice caused by bile duct blockage.
Okay, so specialist centers, MDT approach. What about the specifics of the treatment plans?
Right. The comprehensive care plan covers everything: treating the tumor, psychological support, managing pain effectively, sometimes using EUS-guided nerve blocks called neurolysis, and relieving biliary obstruction. For resectable head cancers, sometimes a variation of the Whipple's called a pylorus-preserving resection is considered, though standard lymph node removal is always part of it.
And for those whose cancer can't be removed surgically, unresectable disease.
It depends if it's locally advanced, hasn't spread far, but involves major blood vessels, or metastatic, spread to distant organs. For locally advanced, systemic combination chemotherapy is the mainstay, sometimes followed by chemoradiotherapy. For metastatic disease, if the patient is well enough, good performance status, the first-line chemo is often a strong regimen called FOLFIRINOX.
FOLFIRINOX, right.
If a FOLFIRINOX isn't suitable or stops working, other chemotherapy options are considered, like gemcitabine-based regimens. And because these patients are at high risk of blood clots, venous thromboembolism prophylaxis, usually with low molecular weight heparin, LMWH, is typically given during chemotherapy.
Palliative care must be incredibly important throughout.
Absolutely crucial. Palliative care isn't just for the very end. It's about managing symptoms and maintaining quality of life from diagnosis onwards for many patients. This includes sophisticated pain management, nutritional support, often needing pancreatic enzyme replacement therapy, like Creon, to help digestion, treating biliary obstruction surgically or with stents, maybe a bypass like a gastrogenostomy if the duodenum gets blocked. It's a whole package of DARE.
Yeah, mental health support too.
Yes, definitely. Depression rates are unfortunately high in pancreatic cancer patients, so screening and appropriate psychological support or treatment are vital parts of the care plan.
So chemo, radiotherapy, surgery, who makes the final decisions and referrals?
Chemotherapy and radiotherapy decisions are made by specialist oncologists, always after discussion in the MDT. Urgent referral pathways exist to get patients suspected of having pancreatic cancer seen quickly at specialist centers or by gastroenterology. Surgical decisions are made by specialist pancreatic surgeons, again within the MDT context. And as we said, even after potentially curative surgery, adjuvant chemo is key to improving those 5-year survival figures.
Which brings us back to prognosis. You mentioned the stark overall figures earlier. Can you recap the UK survival stats?
Yeah, it's tough reading. In England, the 1-year survival is around 25%, or maybe slightly more now, but 5-year survival is still only about 7.3%, and predicted 10-year survival is just 5% or so.
And any differences within those figures?
There's a slight survival advantage for females compared to males at 1 and 5 years, and perhaps unsurprisingly, younger people diagnosed under 50 tend to have better survival rates than older patients. But the big picture is that, unlike many other cancers, we haven't seen significant improvements in overall pancreatic cancer survival in the UK over the last 40 years.
That's really sobering. Is there anything known about prevention beyond the risk factors we discussed?
Well, avoiding or stopping smoking is the single most effective preventive measure anyone can take. Maintaining a healthy weight through diet and physical activity, particularly avoiding central obesity, belly fat, is also advisable. A diet rich in fruits and vegetables is generally recommended. There's been some research suggesting NSAIDs might have a protective effect, but that's still speculative, not a firm recommendation.
And what about screening for people known to be at very high risk?
Yes, for certain high-risk groups, surveillance is now recommended. This includes people with chronic pancreatitis, especially hereditary pancreatitis, those with a strong family history, familial pancreatic cancer, or individuals carrying specific genetic mutations linked to increased risk. NICE's guidelines mentioning BRCA1, BRCA2, PALB2, CDKN2A, genes linked to Peutz-Jeghers syndrome, and others.
And how is surveillance done?
The main tools are imaging, usually alternating between MRI-MRCP and endoscopic ultrasound, EUS. For specific mutations like PRSS1, linked to hereditary pancreatitis, pancreatic protocol CT might be used. Interestingly, EUS is not generally recommended for detecting cancer itself in hereditary pancreatitis, more for looking for pre-cancerous changes.
Okay, that's good to know about surveillance. Finally, let's touch on the main complications that can arise from pancreatic cancer itself or its treatment.
Right. Complications are common and can significantly impact quality of life. Key ones to remember. Obstructive jaundice from the tumor blocking the bile duct, causing the yellowing, itching, pale stools, dark urine we talked about.
Okay, obstruction of the bile duct.
Then duodenal obstruction. The tumor can grow to block the duodenum, causing nausea, vomiting, bloating, inability to eat. Also, thromboembolic events. Patients have a much higher risk of deep vein thrombosis, DVT, and pulmonary embolism, PE, which can be life-threatening.
So obstruction, biliary and duodenal, thromboembolism.
And finally, intractable pain. Pain can be a major issue, often severe and difficult to manage. It can come from the tumor pressing on tissues and nerves, inflammation, or complications like biliary stenosis. So maybe think ODTI for the main complications: obstruction, duodenal obstruction, thromboembolism, intractable pain.
ODTI. Got it. So wrapping up, it's clearly a really complex and challenging cancer, with diagnosis often late and prognosis remaining poor despite our best efforts.
Absolutely. It highlights the urgent need for better ways to detect it earlier and develop more effective treatments. Continued research and raising awareness of those subtle early symptoms are just so crucial.
A critical area for ongoing work. Well, that brings us to the end of this deep dive on pancreatic cancer. Hopefully that's been a useful high-yield run-through for you. If you want to test yourself further or explore other MSRA topics, do check out passthemsra.com.
And for more free revision resources, including notes and questions, head over to freemsra.com.
Thanks for joining us on the Deep Dive.